If you can see me and if you can see the slide, is that all okay?
Yes.
Yes, all
Perfect, perfect, perfect. I think all systems are working then. We should
Mm.
start. All right, hello and welcome. Assalamu alaikum. Thank you for joining for this free AMC clinical exam sessions. Now, this session is a prelude to the exam course that we are all starting in the first week of May. And it basically will highlight the organization of the AMC exam, what it's all about, how to prepare for it, what books to use. We'll do a couple of clinical scenarios as well, just to give you a bit of flavor of how the exam is organized and how it works. So first of all, about me, my name is Rizwan Qureshi. Some of you may know me through Emergencyfocus. I'm working here as a consultant in emergency medicine at Wollongong and Liverpool Hospital for the last 6 years. I'm an IMG from Pakistan, and I've graduated from Dow Medical College in 2001. And I've done a lot of hard work, as most of you have also done a lot of hard work. Now, I've passed AMC, PLAB, MRCS, and Australian Fellowship Exam, and also currently teaching on various courses, plus Australian Emergency Fellowship Exam. So I've done a lot of effort teaching various exams and workshops. So I come here from certain level of experience assessing the candidates and how, to feedback them constructively to better utilize their own talent to pass any exam without much of an effort. Does it make sense?
Yep.
Cool. Now, today's session, we're going to break it down into a number of components. So first, we're going to talk about AMC Clinical Exam. We're going to talk about how to plan for the AMC Clinical. We're going to talk about the strategies of how to efficiently gauge your study to pass the AMC exam. That's very crucial. What are the top reasons to fail? We do some exam scenarios, as I said, just to give you a flavor of how the exam is conducted and how the scenarios are organized. And at last, we'll talk about the very important aspect of the exam, which is the communication skills. What verbal and non-verbal communication skills are required to perform at your peak to pass the exam. We're going to also touch base on some of the books which you can read as a resource for this clinical exam. And then I'll open the pod for any Q&A session, any questions that you may have. So we'll let all of the session run smoothly, and we'll take Q&As at the end. But having said that, if you're not able to understand me, or if you've got any questions, please stop me and ask me, especially if there's any technical glitches. I'm not that tech savvy. So first of all, I know all of you would come from various backgrounds. Some may have done AMC1, some may have not done AMC1. So I thought I'll just keep it very basic and simple. So first of all, we'll talk about the level of the exam. So where is this exam pitched at? Now, as per AMC, this exam is pitched at newly qualified medical graduates who are about to start as an intern training in Australia. But there's a catch in it. When you apply for a job as an IMG, you're applying for a job at a resident level. So what does it mean? It means that you're expected to assess the patients, take history, do the examination, do appropriate tests, and make the management plan and discuss with your consultants. Also, if you're working in a GP practice, then individual patient assessment, making the complex management plans according to our acute and chronic health needs, and then collaborating with the medical specialties and specialists in the hospital, and also the disease prevention, health education, community education in the community. So I'll also talk about the dates of the exam. Now, up until, as you most of you would know, that this exam has gone online now. Until about July 2021, the AMC website says that they are doing special scheduling. What it means that due to cancelled exam last year because of the COVID, this year the priorities are given in terms of dates to the candidates from March up to June 2020. So those candidates who missed the exam in between March and 2020, who were meant to be taking their exam, they will be offered the online clinical exam dates. But I'm expecting surely as the system runs more smoothly, they will open up more dates, especially the online dates, and they will start trialing some of the physical exam as the vaccine rollouts and the community prevalence of COVID is low. So I think it's all going to improve as the time goes on. So if you're preparing for exam, please don't be complacent. Be on your guard because you may apply for a date and you may get soon, or you may be surprised of the date which will come in a few months time. I'm not sure exactly how soon the dates are available, but if you are one of those candidates who have actually scheduled to be having the exam between March and June and you apply now, it's pretty much a guarantee that you'll get an exam date within 3 to 4 weeks. That's what I've been told. Now, online exam is 16 station, which are assessed, of which 14 are marked. 2 are pilot station, which are not marked, but are counted if your stations are not performing top level. So they can be counted for your overall domain assessment. There are rest stations in the online exam as well. You need minimum of 10 stations to pass, as you know, but we'll talk about that. Now, AMC Clinical Exam is based on 2 main things. There's a scenario and there's a task. That's very simple. Everybody is aware of that scenario and a task. So
Yes.
so what is a scenario? Scenario is basically a clinical conundrum in a field of medicine, in a field of surgery, obs and gynae, pediatrics, mental health, at a final year medical student level who are, as I said, about to start their intern training. The scenario may be actual patients, maybe simulated patients, maybe a video, maybe a chart, maybe image, maybe anything. Then what is the task? What is the task? Can anybody tell me what's the task?
Yes, it can be like take history or perform a physical examination or outline the management, or it can be a counseling station. Yeah,
That's right.
I think
That's right. Rashi, you're absolutely right. So task is exactly that. It's history, examination, diagnostic formulation and a management plan, and counseling and patient education. Now, that's where you will be judged in terms of the marking scheme, the history taking from the patient, from the carer, from the parent. And I often emphasize remember to be focused because it's a time capped exam. So remember to take focus history, provisional and differential diagnosis based history. For example, if you've got a patient chest pain, diagnosis based on ACS, PE, aortic dissection, and musculoskeletal exclusion first. So you've got the critical fail things out of the way first, and you can score more marks and less chance of critical errors. So we'll talk about that in a little bit more detail in a while. Now, examination, how to do online. It's a bit tricky, but I'll go through in a bit more detail. In an online format, basically, you're tested at a higher level because here you're not able to demonstrate your physical motions of conducting the exam. So you're judged in terms of, for example, if you've got a patient with a back pain, higher level means focus diagnosis based approach. Basically, what it means that based on your history and you will consider a neurological examination, a musculoskeletal examination, a gait assessment, a lower limb neurovascular assessment, and even a rectal exam. But you have to talk the examiner through that. You still have to go to the motions of, that look, I'll approach the patient, take the consent, ask about the comfort level of the patient, and then I'll proceed on with my assessment in terms of inspection, looking for any scarring, any deformity, any postural changes, and then working so on. Because you have to describe in detail, as I said, you have to tell everything: inspection, vitals, localized inspection, a special test that you might do. Okay. And the information you may have to give to the patient if the scenario asks it, or you may have to give it to the examiner, or sometimes there might be a medical student who needs a bit of a guidance examining a patient with a lower back pain, or there might be a junior doctor who needs some help with assessing a patient with vertigo, and so forth. Diagnostic formulation: what is all the history and examination pointing to? What is your main provisional diagnosis? What are your main differentials? I think this is the most important aspect where candidates break off and fail. We'll talk about how to form a diagnostic. What's the simple way of actually clicking off the critical diagnosis first? And at the end, management, counseling, patient education. That's where your communication should be at peak, really, where you're really stemming and consolidating all of your assessment. Okay, now moving on. Is everybody clear? No questions at this stage?
Yep, all good.
All good. Let's move on. So, how's the exam mark? As you know, that there are three components to a marking. I've got an exam sheet. I don't know if you can see that exam sheet very clearly. Sorry, I could not blow it up, but I'll try to do that. Can you see that? I think it might come on a bit more clearly now. So, exam basically is just the marking is in three components. This is called key steps, domains, and overall global rating out of 7. So the key steps you can say is more like a critical error. For example, in this marking sheet, which is a sample marking sheet, you've got a candidate who is being assessed from the point of view of shortness of breath. And they're obviously thinking about differential diagnosis of pulmonary embolism. So working in terms of asking recent travel history, oxygen saturation, and considering the diagnosis of pulmonary embolism. So these are the critical errors which you must not miss. If you miss them, then obviously it's going to be a no, and it's going to be very difficult if that component of key historical finding is not addressed anywhere else. You'll be very much trouble to pass that station. Now, domains are basically an organized approach, organization of the tasks, communication, um, and when completing the given task, are you really following the task? So the task, for example, may be to take the history, to conduct the examination. But if you're not doing that task, you're pretty much missing the boat. So domains are assessed there and then global rating is, as I said, it's a mark-based assessment predominantly in the areas of history, examination, and management. And as you can see here, this is the seventh, 7 overall global rating is based on 7 score. So less than 3 you fail, and 4 and above you pass. So it's pretty straightforward in terms of marking how you're going to perform in terms of the critical errors, domain assessment, and global rates for overall performance. All right, we'll move on. Now, how to plan for an exam is where most candidates sort of need guidance. I often tell all my, you know, candidates and participants to all our courses, I need to pass all 16 stations. Often people work on compromises. Oh, look, you need to pass 10 stations. And if I do pass, 11 stations, 2 from pediatrics, 3 from gynae, I'm pretty good. This is a very simple exam, really simple exam, which is based at junior doctor level, which is basically assessing you that you're working at a safe level. And if you plan that you're going to pass all station, you will pass the exam. There's no doubt about it. Okay, but if you're working on a compromise strategy that I need to pass 12, I need to pass 4, then it's not going to work out. Now, the other thing is you need to follow how you're going to do that. You're going to need to follow a very simple routine. And I don't want that routine to be grueling. Just be mindful. This is an exam which is practical exam. So every day, something like 4 hours. You may start from 9 o'clock in the morning to about 1 p.m. in the afternoon, and give yourself a night type revision for another hour. So basically 4 to 5 hours study of every day. A routine that you can repeat in terms of making it to perfection. And that routine should be based around the exam scenario. So reading the task first, then reading the question, framework your intro, body of scenario, what communication open lines are you going to use to open up your station, what communication lines you're going to use for closing up the station. So have that very basic strategy from day one. So even if you're studying for a session or scenario, which might be, pediatric or ONG related, just make sure you're practicing to real time, real exam time, because this exam is judging your performance based on the time. You can do the scenario, don't get me wrong, you can do the scenario without any trouble, pass the scenario in 30 minutes, but that's not what this exam is about. This exam is about 2 minutes reading time, 8 minutes performance. And what I want you to think about is to be able to perform and tick up all the boxes in close to 7.5 minutes. That's what we were told in Australian fellowship exam, which is exactly based on the same recipe, that you should be able to finish your scenario in 7.5 minutes and taking at least 80 to 90% of what it's asked. And that is the comfort level where you want to be at. Does it make sense? All
Yes.
right.
Yes.
Now, study, as I said, it's a real-time accuracy. You can work with someone in terms of forming a group, so you can do a group study, but make sure that you're not making compromises when you're forming your group. You need to be forming a group with someone who has got good communication skills. It's a bilateral highway of knowledge, meaning they're giving you something in terms of they may be good in medical knowledge, they might be excellent in communication skills, or they may have a lot of clinical experience working in different countries like UK or perhaps any other country with similar experience. But don't make compromises when you're selecting your study partner, that there's this person who's failed the exam 3 times, is not really worked for the last I don't know how many years. There's nothing wrong with that. You could have that kind of members in your group, but make sure predominantly your group has got a person who is really switched on, who could be the leader of the pack, so as to say, especially if you've not got an exam course that you follow. In exam courses that are conducted, you're automatically put in a group. So you've got that herd mentality, that herd leading pack, imparting knowledge and all that. So that's just my way of sort of rationalizing thing, that whenever you're making a group, make sure that you make the group with the right people. You need to find the right people to have the right recipe from day one. Now, courses are good, don't get me wrong. Um, they are good for keeping you on your toes, and especially if you don't have a decent group. And if you're struggling to find the people, some of the people that you studied with have passed and moved on. Now, just be careful that courses should not be like a boot camp and, vigorous 7 and 8 hours, finishing everything. That's not learning. That's just cramming. You don't need cramming at this stage. You need to build and consolidate the concept. So I think 3.5 session is more than enough per day. Apart from that, it's going to basically saturate you. And as soon as you've done the session at your course, revise that. Revise the core topics which you have been taught that day. And in that way, you'll never ever forget them. And that topic is done. You don't have to open that topic closer to the exam. Okay, so just be more efficient in the way you organize yourself from that point of view, especially when you're doing course. Also, when you're selecting a course, make sure the faculty are up to date. Now that's very important, because the faculty could be someone who are, as I said, passed the exam themselves. They are not the people who are working. But this exam is very ruthless when it comes to assessing. This exam is assessing IMGs who have not worked in the system, but basically on the formula of all the doctors who are working in the system. So you need to have someone who's got a complete understanding at the hospital level and at the GP level, even I would say, of Australian health system. There's a lot of difference between working in India, Pakistan, Sri Lanka, Bangladesh, and wherever you come from, an Australian health system. This system is much more robust. This system actually influences even junior medical doctors. I was working with 2 interns last night in Wollongong Hospital, and between me and 2 other doctors, we saw close to about 18 to 20 patients. And I'll tell you, those interns were marvelous. Their assessment, their communication skills, I did not have to tell them anything twice. So the way that they're educated is completely different to way we are educated. And then the system complements their training and education. So we need to have an understanding of how system works. How can you utilize the tools in the system to pass this exam more specifically? All right. So The system, the system basically is pitched around collaboration, communication, and teamwork. And that's where the exam resides as well. You need to be able to collaborate, ask questions, communicate, and teamwork, meaning referrals, getting the other people, stakeholders for the better management plan for your patient. So it's all about communication and teamwork. Now, also, as I said, that mock exams is also important aspect of courses. Um, why they're important? Because they basically tell you there and then where you stand. And if you've got a course which has got a mock exam, then there's nothing that could be better than that. You can identify the areas that you are struggling with, identify the areas that you're good at, and then you can build up on the areas which need more work. Now, we'll move on. In terms of time, I say you need 10 weeks. Anything. So even if you've not touched any book, I'll be very strict. Honestly, you need 10 weeks. I did my, AMC with my full-time job. I think I had an unfair advantage because I was working in the Australian health system, but I did it within 2 weeks. I had also an unfair advantage having passed the PLAB and all that. So I had already a good way of understanding. So just make sure that if you've not worked in the system or if you've not worked recently, give yourself 10 weeks. And as I said, simple daily routine, daily 4 hours of study, 5 hour stat, and then 1 hour revision in the evening. If you're doing a course, go through all the scenarios that you've been taught in the course in that day so that you'd never forget them. Why do I say 10 weeks? Because in that 10 weeks, you're just making yourself work more efficiently. Anything more than that, you'll make yourself a nervous wreck. You'll be talking to people, other exam candidates, their stories, and it's not going to help you. Remember, you need efficiency. You don't need hours and hours and hours on end. If anything, you'll just procrastinate and you'll just fall off from the perch. So don't lead yourself to confusion and frustration. Give yourself 10 weeks, do the mock exams and the courses, and you will be in comfortable zone. Often we do feel that we're not ready, but the mock exams will be able to tell you where you are at from that point of view. Now, in terms of, we've talked about in terms of studying from the real exam conditions from day one, we've talked about courses. In terms of books, now that's where I often don't advocate anything very strongly, but I'll take an exception to this rule. In this exam, I think Handbook of Clinical Assessment is a must. You're all aware of that book, Handbook of Clinical
Yes.
Assessment by MC. So that's a must book. It's got beautifully written scenarios, exactly how you get them in the exam. So there's no confusion about the mistake of recalls. It gives you, very accurate critical care, like critical criterias or critical areas of pass fail. And it's got a good feedback overall. So you can pretty much direct your own self-study plan from Handbook of Clinical Assessment. Now, Murtha is other book which I like. It's good. It's an excellent reference, especially for all the core subjects like medicine, ONG, GP related topics, especially on counseling, mental health, pediatric cases, guidelines, and immunization schedule and everything. I also like Karen notes. They are good. They're well written. And if you have read them, then you can utilize those notes because they are written in a very good English and very good organization. The only thing about the Karen notes, they're a bit artificial. They just talk in a very binary fashion. This is the scenario. This is how it needs to be done. It does not address the soft core aspect of the exam, which is your, the communication skills, how to intro, how to conduct the body, how to conclude the session. So that's what is often lacking. You cannot read that from notes. This is something you need to practice. In terms of pediatrics, I cannot emphasize enough that you need to read, whatever you're reading from the pediatric source, but also the RCH guidelines, which are updated every so often, and you can get more updated information from there. YouTube videos are good, especially from the examination point of view. But there is a trick in YouTube videos. Look, YouTube videos are often broken down in terms of assessment of the hands, back assessment, cardiovascular assessment. AMC exam, especially the physical exam stations, are not organized in that fashion. So you might be thinking that, oh, I need to follow that YouTube video scenario, how that doctor was doing. But you're essentially forgetting one of the essential components, that this is an online exam where you'll be doing a running commentary. Okay. So,
Mm.
and plus it's pathology sequenced. You might be asked to examine a patient, as I said, with a murmur or with a shortness of breath. So you'll be doing number of a different examination. You'll be taking a quick amount of history from the patient, quick critical question, and doing a cardiovascular and respiratory exam. So it will be a combination of two exams. So try to identify that if the patient is coming with a gait problem, may require musculoskeletal, neurological, and orthopedic exam. It could be an amalgamate of various examination. Not many YouTube videos I'm aware are able to address that kind of need. So just be careful. You can prepare yourself very well indeed by going through the individual assessment, but you may have to structure your own way when it comes to the exam led online exam led scenario that you're expected to do. All right, we'll move on in the interest of the time. So how to pass now? um, this is the system which I've developed and often talk about that. And this slide is basically is to be used before every scenario that you do. Okay. And it's something that I've put a lot of thought and a lot of organization into it. So basically red, yellow, and green light. So outside the station, you read the task first. What am I expected to do when I read the question? All right. Then you read the question. You're outside the station, your 2 minutes has started. Read the task quickly. Okay, I'm expected to take the history, do the examination, and then make the management. Now, what's the question? Oh, the question is about a 25-year-old gentleman who's come in some shortness of breath and wheeze. Okay, then you're already automatically thinking what the scenario may entail. Oh, it might be based on asthma. It might be based on some sort of chest infection, based on the age and demographics. So outside, you have got a complete idea what is wrong with this patient and what I'm going to do. When you go inside, so you've come to the yellow light, read, red, read question, read task, read question, read, diagnosis and organizational thought process. You're not go yet, but you're just basically organizing your thought process. Diagnosis, differential diagnosis, planning of the station. That's all yellow. And then you go green. Inside, what do? You introduce yourself. I cannot emphasize, we need to work on that in a very, very crucial manner. How to introduce, how to obtain a soft consent. That's actually very important to, develop a rapport for an exam like this. And then you do a quick stability check, like if the patient's stable, if the patient's unstable. You develop a rapport with the patient. You explain the plan to the patient that, look, okay, fine, my name is Dr. So-and-so. I'm going to take some history, ask you some questions, examine you with your consent, and then we'll work out a plan how to best approach this situation. All right. Can I get you guys to turn your mic off? Because I think there's a bird in the background. All right.
Sorry, that was me. I'm just switching around.
All right. Now, history, examination, investigation, all that in a very organized way. Diagnosis and differentials and management plan. How do you now? Management is just not talking about the treatment. That's what we often confuse, that management is about treatment. And I actually did not understand that when up until the point when I was doing an Australian fellowship exam, and they said manage it about the general management, the specific treatment, and how you're going to talk about the disposition, like whether the patient needs an admission into the hospital, admission, if it needs an admission into the hospital, is it going to be an ICU admission? Is it going to be a ward admission? Or if you're going to discharge the patient, what sort of specific follow-up advice you're going to give the patient? Plus, on top of that, in this exam, you also need to counsel and educate the patient. He might be having a problem with chest pains, and you may have to counsel him from smoking. He might be a diabetic whose sugars are out of control, and you may have to counsel them from that point of view. So just remember, management here is very detailed, and you need to touch base with all the aspects of the management. All right, moving on. Then you need to, at the end, summarize what you've talked to patient about. Okay. And then say that, okay, if you've got any questions, then ask me. So you don't leave the station or the scenario with any open-ended issues. You've sort of summarized and put the ball in patient's court. Have you got any questions? Is there any concern that I've not addressed? In that way, the patient will feel valued and connected. Now, top reasons to fail: obviously not prepared the subject in detail. Now, there's no substitute for hard work, don't get me wrong. You'll all have different styles of study, but I believe that every exam should put you in a zone, almost to a zone of hard work, edging on to a discomfort, slight amount of pain, if you call. That's your hard work. You need to clock the hours. You need to study the medicine, surgery, psychiatry, all those core concepts which you may have forgotten, but you need to keep on reinforcing that idea. All right. Some candidates don't read the tasks well. That's the other problem. If you're not reading the task, you may have a very good handle of the complete situation, but then you might not be answering the question. So read the task very well. That's what I meant in terms of that red, yellow, and green approach. Stop there. You've got 2 minutes. Read the task and organize that task in your mind. How you're going to approach that question when you go inside. All right. Now, the other thing is poor communication skills. Now, let me emphasize, it's not about your accent. You can have any accent from any background. It's not about your looks, but if you speak clearly and confidently and your plans are safe, nobody can fail you. Remember that. Please. This is I cannot emphasize this enough. It's not about your communication skills are not about your accent and looks. It's about speaking clearly and being very switched on, in complete command and control of the situation. Okay. It's about that non-verbal communication skills of developing a rapport. You don't need accent for that. Okay. It's about detailing the pathological process, the medicine behind it. You don't need, accent for that. So it's very specific that you need to be clear. Somebody said to me that somebody should be, whenever you're talking in an exam scenario, the people should be able to count your sentences. So it needs to be slow at a point where you're trying to emphasize a certain thing, and it needs to be fast where you need to get to the lot of tick boxes quickly. We'll talk about that when we come to the communication skills session at the end of the workshop. Now, you've got no framework. Now, I know the exam is a bit topsy-turvy. Some of the questions are, history, examination, investigation. Some of the questions start with management, but you need to have a framework for each one of them. This is what this exam is basically getting you to do, is to rapidly think and adapt yourself to the different scenario, because that's how the real work is like. You may have to manage a very, very sick patient first and then take the history. You may have to calm down a very distressed patient or relative first and then have to take the history. So just have a framework for every situation. Okay. Nervousness. Now, I can say that almost 7 out of 10 people would be a nervous wreck. I would be a nervous wreck. I was a nervous wreck before fellow. This is natural. But there is certain strategy that you can overcome your nervousness. Look, nervousness can only last for the first 2 or 3 stations. Once you get in a flow, you want to do the task. You want to get ahead of it. There's a certain trick behind that, how to ease yourself into a scenario. And I'll talk about that. Basically, what it means that you imagine yourself that you are in an imaginary hospital or a clinic. You have to make yourself believe that you are living in that scenario. In that way, it will come naturally to you how to talk to your patient. You will not be nervous. Oh, I'm missing that point. I did not ask about that particular question. The other thing is, when you're done with that scenario and the 10 minutes are up, that scenario is done. It's dusted. Please don't think about it. You may have passed or may not have passed, but don't upset your 10 or 12 remaining stations, which you can pass very, very well and could compensate for that bad performance. That's what I like about domain assessment exam, which AMC is. It will be constantly assessing you throughout the rest of the stations. So be very clear about that, okay? Let's do some exam scenarios. Okay, practice is the key. So we'll just do some exam scenarios, how they're all based and how we should work through them. Okay. Has anybody got any questions at this stage before I dive into this exam scenarios? You can unmute your mic if you like.
Yeah, I got one question. I was like trying to book a mock exam, as you said, but I couldn't find any. Are there any mock exams available in any of the institutes we know?
Okay. I'll come to you. I'm sorry, I didn't get your name.
My name is Danushka.
Okay, Anushka, we'll come to that at the end of this, if that's okay. Any other questions related to what we've talked about?
No.
No, all right. Okay, we'll move on. So exam scenario 1. So basically what I've done, I've selected 3 very common scenarios, and I thought I'll just go and give you a bit of flavor how I would, like to be doing them. Okay, so we'll jump right into it. So 6-year-old boy Jaden has been brought into your general practice. In fact, Dr. Rashi, are you there?
Yes.
Would you like to read this scenario for me, please?
Yes, sure.
Thank you.
Okay. So 6-year-old boy Jaden has been brought in your general practice by his mother, Mrs. Jackie Roberts. Jaden has been complaining of pain in his right hip for the past 3 days. In the last 2 days, he has started to limp. There is no known history of trauma and fevers, but Jaden did have mild sore throat last week. Mrs. Roberts is quite concerned about Jaden's mobility.
Okay.
Okay.
And tasks, please.
Okay, tasks are take focus history and ask for relevant examination, formulate a diagnosis and subsequent management, explain Mrs. Jackie Roberts your plan.
Okay, now just stop right there. And Rashi, I'm pretty sure you've got at least 50% idea right now, reading this scenario, what this is all about, right?
Yes.
Isn't it? Yes. What do you think? Like, what's the first thing which is coming to your mind? Let's talk about what's the first thing which is coming to your mind in terms of diagnosis.
I'm actually, no, it's, I'm actually out of words. I know what it is. It's got a history of viral infection.
Yeah. Just put anything out there.
Okay, so somebody's just written reactive arthritis.
Okay, all right. Reactive arthritis. That's a very fair point. Okay, excellent. What could be the other thing?
Transient synovitis.
Perfect. Exactly.
I was trying to find the word. I was like, tenosynovitis, or is it synovitis? Yes, transient synovitis.
That's right. So transient synovitis, somebody's written about Perthes disease. That's right. So you've got a fair bit of an idea. And I'll tell you one thing. I'll tell you all one thing. You're all 100% right. Now, do you think this scenario is about the diagnosis?
I think it's about the plan.
It is about the diagnosis to a certain extent because they do say formulate a diagnosis and subsequent management plan based on the diagnosis, right? Yeah. So diagnosis is only a part of the question. The other question is take a focus history and ask relevant examination questions. So that's where you need to be inventive and creative. All right. The other part is also talking to the mother, Jackie Roberts, about your plan. Now, you know what a typical doctor like us would do? They will be, I got the diagnosis right. It was TS, transient synovitis and Perthes disease. I nailed it. There's no way I'm going to fail this scenario. But you know, the essential component of the exam is also about taking a very focused history, doing the examination. And if you're not doing that, according to what their expectation is on paper, you're not going to do well in that. But before you do the focus history, so that's what's written on paper. There's also an area which is not written on paper, and that's your introduction, how you approach a very concerned mom. Let's jump into it. Okay, I'll show you the x-ray. This is the x-ray. Okay, so I'll save time. This x-ray is essentially normal. It does not show any component of Perthes disease. Okay, it hasn't got any fractures or dislocations. It's a typically normal X-ray of the pelvis. All right.
Mm.
So I'll do the scenario in terms of how the expectation would be, and then we've got some other scenarios, and we'll see how we go, and we'll take the questions and the feedback from the rest of the participants as well. Okay. So remember, the tasks were take a focus history, exam, and plan the investigations. Okay. Diagnosis and different. So that is what I'm breaking down. Let me take you back. So the focus history was what? Take a focus history and ask for the relevant examination, formulate a diagnosis and subsequent management plan, and explain. History, exam, diagnosis, plan, and explaining plan. All right. Now, we're inside the station. First of all, introducing your introduction is vital. All right. So
Mm.
what I've done is I've broken that task in my mind. I'm thinking that, okay, fine, I'm going to go in, I'm going to take a focus history, and I'm going to do the exam, and I'm going to plan my investigation based on that examination findings.
Mm.
After that, I'm done. I'm going to talk about the provisional diagnosis and differential diagnosis, and I'm going to come up with a management plan. And I'm going to talk to the mother and explain that plan. That's what I've decided outside the station. Now, as soon as I move inside the station, what I do, I open up.
Mm.
I open up with introduction and consent and stability check. So I can say something like, "Hi, Miss Roberts. My name is Dr. Rizwan Qureshi. I'm one of the doctors in this practice, and I believe you're very concerned about Jaden's mobility and right-sided hip pain. Is that right?" She'll say, "Yes. Look, I can understand these problems can be very concerning for a parent. Miss Roberts, what I'd like you to do is ask you some question, and with your permission, I'd like to conduct a medical examination. And this will help me work out if there's any tests that we can do which are required to base or to work out the diagnosis. What we'll then do is we'll work out together for a suitable management plan. Is that okay with you?" So that's my ballpark introduction. In that way, not only I've frameworked my entire 8 minutes, what I'm going to do, but I've taken a consent for examination, and I've highlighted that I'll be doing some tests, and then we'll be discussing a management plan. So God forbid, if I run out of time, examiner, if he's got a little bit of heart, he can say that, look, Rizwan did have a plan, that he's going to do a history examination, he's going to do some tests, he's going to have a chat to the parents. He did have plan for that. He ran out of that time. Now, there's one other crucial aspect, which is a requirement for this station. Anybody guess what that requirement is?
Lev-
Anybody?
level
What's
of
that?
level of pain.
Excellent, excellent, excellent. So before I proceed, would like to ask if Jaden is comfortable, or does he require anything but the pain? And also at this stage, I'll just factor that in to the examiners that, look, I'd just like to know what is the recent set of vitals, if the patient's stable, because he did have fevers, not now, but before. Could he be a septic arthritis and unstable patient? Just throw it out there. You're not going to get D-marked from that. They may say, yes, vitals are okay. Now, focus history.
But I just have
Now,
one question. Sorry, I'm interrupting you. But in the history, it's already given there's no fever. So does that cut your marks if you repeat it in your history?
that's a very good question. So I'm not asking specifically for a fever. I'm asking for that like a latest set of obs, which would include
Okay.
heart rate, blood pressure,
Yes.
oxygen saturation, and temperature.
Okay.
All right. So this patient has come in with the hip pain, of which one of the important differential to be considered is septic arthritis. Okay. I'm not saying it's a trick scenario. It's a very straightforward scenario, but that asking for vitals demonstrate it to the examiner that I am actually very concerned about septic arthritis on the background. All right. Once the information has been relayed to me that there's no fever, I'm happy and I'll move on. Okay. Now, in terms of, does that answer your question, Rashi?
Yes. Thank you.
Okay, okay, okay. We'll move on. So focus history. So very quickly, I just said that basically you can either do, there are two forms of focus histories. You can either do a diagnosis based history, like a diagnosis of transient synovitis, and then work out the questions related to the diagnosis, or you can do a history in terms of pain, in terms of triggers, duration, location, severity. It's entirely up to you. They're both relevant and fine. And you can fluctuate between the two models, and we'll work through how and what's the best way. So what I've done is what was the trigger for that pain? How did this pain start? How long have you had this pain for, Jaden? And can you please tell me where the location of this pain is? Fine. And now, can you please tell me out of 10, what would be the severity of the pain? Now, is it radiating down to your knee, into your back, or anywhere else? Now, you've had this pain for about 3 or 4 days. Can you tell me what would be the aggravating and relieving factors? Does walking, climbing stairs make it worse? Have you been having any other issues in terms of having falls? Perfect. All right. So that's all. I'm triggering the pain sort of line getting out of the way. And if any of that scenario or in any of that key component is a part of the history taken, I've done that there and then. Other thing is any associated features which are red flags, any fevers. Now, it does not say that he has had fever in this scenario, but just ask them again to highlight the same relevant point that he's not got any septic arthritis. Now, also one thing I'd like you to add on, and I don't know if you're adding that on in terms of your historical assessment of the patient now, ask, which I do practically now with all my patient, if this has happened before and what was the outcome of that. If you've had this kind of hip pain on the other side or this side, then you have got a level. Oh yes, I did have that kind of hip pain, and that might say that okay, fine, this patient has had an ongoing hip pain issue for a while now, and it has been investigated with x-rays and all that. So I think that could be a practical tip. If there's a chronic, acute and chronic problem, that could be especially relevant for patients who are presenting with back pain. For osteoarthritis, they may say that oh, they've had x-rays before or MRI or CT scan before. It's just a practical tip which will save you a lot of time and effort. Now, inquire about, he is a child. He goes to school. He's participating in school sport. Okay, so inquire about what sort of school sports they do, like what sort of sports they do. Have they had any fall or any sort of injuries at the school, local school sport? Also ask about the sore throat last week. What was it like? Did they get treated with any antibiotics? How long was he unwell for? Was that any association with swallowing difficulty or breathing difficulties or any of the associated features in terms of rash? So you've excluded that sore throat differential diagnosis line. Now, quick past medical history. Because it's a history, you need to cover all the parts of the history. So quick part medical history in terms of birth history, immunization history, nutritional facts, developmental, any current drugs that he's taking apart from analgesia at home, social history in kids about schooling, about parenting, about psychological well-being. Okay. And you don't have to factor in any other irrelevant information in terms of alcohol or cigarette smoking if he's a 6-year-old boy. Nobody's going to penalize on that. Psychological history is definitely important, and just make sure that you put in a soft question that everything okay at home. There's a lot of scenarios which may have a component of bullying or some sort of trailing online. So just touch that. If everything okay at school, has everything been going on with your friends? Have you got friends at school? So that shows on your holistic approach, um, as opposed to being task driven, that oh, I need to get this hip pain out of the way. But putting in psychological well-being of a child is equally important. Now, when you start exam, you can ask for the vitals, that look, I'd like to have a set of recent vitals. Now, one of the key thing is, and you will fail this station if you don't examine the entire of the right lower limb. Now he's come in with the right hip pain, but if you don't examine the right knee, right hip, right knee, right ankle, down up to the level of toes, you will fail this exam. This is actually one of the feedback of this exam as well. That was a critical fail. If you've avoided to listen or examine the right side of the limb, lower limb completely, or examine the other side as well. So left lower limb exam as well. Also mention that you want to do a quick ENT exam, chest, CVS, and cardio. You can just quickly mention it because it's all online. You can talk about it. Now, examine again, it's virtual. You need to start off with that before examining that. Look, I'm going to have a look at your leg, and I promise I'd be gentle. And if it hurts, do let me know. And By putting in that effort, you've demonstrated that you're actually a human being, not just an exam candidate. You know, the point that I was trying to make earlier, you need to put yourself in a zone that you're actually with a real patient. Once you put yourself in that zone, everything will fall naturally. You don't have to think of next step. Just imagine yourself in that zone. And with that practice that you keep on doing, you will come into that zone. Okay. Now with the joint, moving on, ask for the vitals, as I said, in terms of temperature and heart rate. We've done that. In terms of any joint exam, look, feel, move. I remember I used to work with this orthopedic surgeon many years ago. He said, look, orthopedic examination is very easy. All you got to do is look, you got to feel and palpate, and you got to move the joint. And if you're feeling a bit more enthusiastic, ask the patient to mobilize. So that's exactly what you're going to do. Look, no external swelling, bruising, rash over the right hip or the left hip, over the knee, over the ankle. Feel for any localized tenderness over the interior of the right hip, groin area, for any lymph nodes. Check for any localized back tenderness and any of the ankle or foot tenderness. Very important, as I said, to examine the whole of the right limb. I can tell you why it's important, because I have been so much surprised in which the patients in this age group have come in complaining of hip pain and they have got femur pathology, knee pain and they've got ankle pathology. They're very non-specific when it comes. And younger the patients are, the more confusing the details of their examination would be. Now move. Quite specifically, if you've got a differential diagnosis of transient synovitis, the painful abduction and rotation of the hip would be there. And if you said that I would like to assess for the abduction and adduction, and can you please tell me the findings, the examiner may say that, look, he's got painful abduction. Now, remember, septic arthritis is a condition in which all movements would be compromised. He would not be able to move the joint at all. It won't be just abduction and rotation of the right hip, which you would get with transient synovitis. Okay. This is just a specific point regarding this scenario. As I said, contralateral left lower limb examines normally or abnormally. You have to make a comment on that. At last, move, mobility. Now, Jaden is unable to mobilize due to severe right-sided hip pain. So you don't have to sort of emphasize that point over and over again. Now, based on all of your examination history taken, you can say that, look, I've examined Jaden, and most likely diagnosis based on my history and examination is transient synovitis of transient synovitis of the right hip. Now, let me just stop there. It's very important when you're making your provisional diagnosis, give it a complete name. Don't just say irritable hip or reactive arthritis. It's just like a blip diagnosis. I don't want you to do that. I want you to come with a scientific evidence. I've examined Jaden, and based on my history and examination, he's got transient synovitis of the right hip. Then you can turn towards the parent and say that it's also called as an irritable hip. It's a soft tissue. It's a it's a self-limiting condition which involves the inflammation of the lining of the right hip joint, and mostly it can happen after a minor trauma. As you remember, Jaden was taking up some sports. He was also unwell with some upper respiratory tract infection symptoms, and that's the other trigger which can cause this problem. The other possibilities could be septic arthritis or infection of the hip joint. So remember, because you're talking to the mom, you're giving the medical diagnosis and you're translating that into a layman's term. The other diagnosis could be a Perthes disease or a late presentation of congenital hip problem, which I think it's very rare and it's not relevant here. So you've given your provisional diagnosis and then you've put on 3 differential diagnoses. That's your diagnostic formulation. But hang on, there is more than that. Okay. Now, investigation. When you're talking to the mom, you need to tell them that, look, that's where you'd be judged in this specific scenario, how you developing your repo and explaining the plan. So basically what you need to say that, look, I think it's a transient synovitis, but my main concern here is septic arthritis because he's really not walking, which is a bit out of character. Although it's unlikely, I would recommend that we do blood tests like full blood count, CRP and ESR to check in for septic arthritis. We can also get in for an ultrasound of the right hip to make sure there's no inflammation within the joint space. and there are no features of septic arthritis. Since the x-rays of the right hip are normal, it's very unlikely that we're dealing with a condition called Perthes disease or congenital hip problem. But I will discuss this with my senior or an orthopedic surgeon on call to make sure they're happy with my plan as well. So in your investigation plan, you've laid a framework. You've already alleviated the anxiety that, look, you think it's an irritable hip, which is a self limiting condition. But just to be sure, you're going to exclude a septic arthritis. You're going to have a chat to your senior to have an interpretation of the x ray, which has been shown to you. And that's how Australian system work. If the child is coming limping, you're not going to be the end authority. You're going to make sure that you talk to your senior, talk to the orthopedic surgeons, talk to the emergency specialist, or wherever you are working, senior GP practice doctor, and make a plan from that point of view. Now, in terms of the management, that's the third aspect of assessment that the task was that, look, if the investigation of the blood tests and the ultrasound of the hip are normal and the orthopedic surgeons are happy with the x-rays, the management of the irritable hip is based on bed rest, analgesia, and follow-up. So I would recommend to have a bed rest for about 24 to 48 hours. That will help minimize the walking and also help settle down the inflammation. Now, if you think that he's not able to walk, we can try some crutches. So give your patient options. If you're advising for a bed rest, do you think if the patient wants to mobilize, go to the toilet? And that's for any patient. Enable them. Can they be given crutches? Can they be a single hand crutches? Is there a carer who can take them to the toilet? So just be very cognizant of the fact this is a patient who would have all the normal humanly needs. Okay. Also, then moving on to analgesia part of things, I would like to start Jaden on ibuprofen, which is an anti-inflammatory and I think has got good results in these sort of condition. And you can talk about the dose if you like. The AMC particularly does not talk about the dose. I'm not sure if they will be asking you to specifically um, highlight the dose, but normally the dose of anti-inflammatory medication like ibuprofen is very simple to remember. It's 10 milligram per kilogram per dose 3 times a day. Now, give them a plan. It may take up to a week for symptoms to completely resolve. I'm happy to give you a medical certificate for Jaden's school and a carer's leave if you're looking after Jaden. What we suggest is that we do a follow-up x-ray of the right hip, which can be done, if there's an ongoing concern with the recurrent right hip pain to exclude Perthes disease. Now, remember that Perthes disease can often get better and get worse, get better and get worse. So you need to organize a follow-up from that point of view because he is in that right age group. And by doing that follow-up x-ray, you're actually closing that loop that I'm not completely ignoring that just based on a single x-ray. And that's where that question that if that hip condition has happened before was so relevant because you were thinking about the Perthes disease. He may say at that point, or the mothers might have said at that point, yes, he's actually had off and on hip pain. And that would have automatically switched you thinking about the Perthes disease in this scenario. Now, coming back to your main provisional diagnosis, be mindful that TS or transient synovitis or irritable hip can recur in 20% of the cases. And it's not your fault, it's not his fault, it's just the way it is. Okay. Now, as I said, the management also involves disposition. Just make sure that you have got a closed loop of disposition. Just say, I like Jaden to follow up with the GP next 2 days, just to make sure his condition is not deteriorating. In the meantime, if he becomes unwell with more pain, more limping or fever, please take him to the hospital. So in that, you've laid a very good management plan based on your assessment, your blood test, your discussion with the specialist, your analgesia strategy, your follow-up strategy, your contingency strategy in terms of septic arthritis, how and when to present. You've just put knots at every plan. It's not like an open-ended plan. At the end, now it's not finished yet. At the end, summarize. And you can say that, look, at the end, I'd like to just summarize and tell you that this is a very common condition. I don't want you to worry about it. It will get better in due course. There are few things that you need to keep an eye on for, which is if the mobility is getting worse, if you spike in temperature, and if you've got any concerns, just bring it back. Now, I know this is a lot of information, so I'll give you a discharge letter and information on about transient synovitis. But if you've got any questions, I'm happy to answer. Okay? Then thank the patient and the family and move on to the next scenario. Now, I'll stop there for 1 minute and take any questions if you've got any.
No, thank you very much. All good.
All right. Any questions from any point of view, any corner? I think Rashi is predominantly the active one here, but if anybody has got questions about this scenario in specific, any communication issues here, or anything that they'd like to do differently, which might be beneficial for other candidates.
I have a question. So in a focus history and detailed history, so what's the difference between that?
So look, the task said focus history, meaning that you start with the musculoskeletal history. I believe that you've come in with a pain in the right hip. Let me ask you some question. How did the pain in the right hip start? Did it start by trauma? Were there any triggers of infection? Was there any other issue of recurrent or repetitive strain? Detail is tell me why have you come to the hospital? Open-ended. Okay, so that's the kind of you're giving patient the complete charge of telling you, I've come here with shortness of breath. Okay, yes, tell me more about it. So you're asking non-leading questions. The focus history could be more based on leading questions in the interest of the time, because there's so much to get through. Does that answer your question, Farana? I've come here with. Okay, I'll take that as a yes. All right, we'll move on.
I just had a question.
Okay.
I just wanted to know that during this time duration, you had said that we can also examine the whole examination, like we could examine the respiratory system. Obviously, he has had cold, so obviously we should also go through that. So this is a focus history examination scenario. So should we focus first on the limb examination directly, or should we first to get the respiratory out of the way?
Very good question. Very good question. Excellent, excellent. This is a focus history examination. The bare minimum to pass this exam would be a complete lower limb examination. In fact, thank you for bringing up this question. You then say to the examiner, I would also like to complete my examination by examining the ENT, chest and cardiovascular system to look for any other sources which could have triggered the septic arthritis. Just make a thought process there. The thing that you must do and must not miss is the complete lower limb examination on the right side and a quick assessment of the left side as well. It's pretty much the same deal when you're doing an abdominal examination. You're not expected to do a rectal examination, even if you're doing a fellowship exam, right? But you'd mention to the exam. So you focus on the aspects of the examination which can be easily and timely done, but mention the aspects of the care which are important, but you cannot do them in the time constraints or privacy constraints. Does that answer your question?
Yes, thank you. That does. Thank you.
Okay. All right. Okay. Moving on. All right. Any other questions or we move on? Okay. We'll move on. I'll just get you to switch on your mics to mute if you like, please. Can I
Dr. Rizwan?
Just, yep.
No, okay. So you were asking what else we can add on. I don't know, this is just a thought. Maybe we can add on by giving the mother some reading material about.
Yep. No, I've said that. You're, because this is so basically there's a way of saying that no, I know it's a lot of information, and I'll give you a discharge letter and information about the irritable hip or transient synovitis. And if you still got any questions for me, you're more than happy to contact me. But that's a very good point. It's actually one of the closed loop communication tools by giving a written information.
Okay.
All right, moving on.
Dr. Rizwan, sorry, I have one more question about the hemodynamic stability. This is regarding because it's a Zoom exam and you don't see the examiner or they're not talking to you. There's been reports like that happening. So how do we approach hemodynamic stability in the beginning of the case?
Okay, you simply ask for it. So there are certain examinations or certain scenarios which lend themselves to a patient who is very sick. the patient, for example, who's come in with extreme shortness of breath or dyspnea, you cannot move on that patient without asking for the vitals or hemodynamic status. So before you begin anything, you introduce yourself and you say to the examiner, look, before I move and conduct the task of examination, I would like to know if the patient is stable or unstable. Can I have the latest set of OBS, please? Because if the patient is not stable, I'd like to move the patient into the acute or resuscitation area. Or if you're in a GP practice, I'd like to call for an ambulance to take the patient to the hospital while I'm completing my initial assessment. All right. So there is no, because it's a virtual environment, you said, there would be no a patient acting as in like he's unstable or anything like that, but you can ask for it. You can ask for the vitals. Does it make sense?
Yes. Okay.
All right. Okay. We'll do the second scenario. Again, I just want you to use this framework as your baseline framework. Most of you who were not able to join us, just this framework is based on red, yellow, and green lights, reading the task first, reading the question, diagnosis, differential diagnosis, and management plan, and then moving on through the various components of the tasks. Now, can I please get all of you to put on yourself to mute? There's some background noise coming in, which is really affecting this. Yeah. Okay. Thank you. Thanks very much. All right. So scenario. Okay. Scenario is about you're working in a general practice and your patient is a 63-year-old retired postman, Mr. Simon Peacocks, who's complaining of neck, back, and shoulder pain for the last 6 weeks. The pain is described as a dull ache, which is constant. The pain is often severe in the morning and with back feeling very stiff. It then eases off during the day with movement. He's also complaining of feeling weak in his muscles over the last few weeks, and he thinks he may have lost some weight and feels hot and sweaty at night in bed. Tasks are to take focused physical examination, provisional diagnosis and investigation, answer question which the examiner would ask you, and advise the patient about your diagnosis and further management plan. Now, I want you to just absorb that for a moment. Now, can I please, there's someone who is still not on mute, and I think we're getting a fair bit of background noise. Is it Kamrun Nehar? Can you please mute yourself? Perfect. Thank you very much. All right. Okay, we'll start. Okay, so the tasks are clear. You're meant to be conducting, so it's not like a taking the history here. You're starting off with the physical examination, you're making a diagnosis investigation, and then the examiner is asking you some questions. And then you need to advise patient about your diagnosis and how to go about managing that diagnosis. So the patient is a retired postman, and you're able to, the first step in this task is to conduct the examination. So here is again, you can say that I would like to start by obtaining a consent for the patient physical examination, and can I have the recent set of OBS. Now remember, whenever you're coming to the physical examination part of the task, always start with a set of vitals, which includes temperature, heart rate, blood pressure, oxygen saturation as a bare minimum. If you're concerned, you can also ask for the blood sugar level, especially if the patient has got a history of epilepsy, has come in with seizure, or this patient has got a low level of consciousness. Blood sugar, in fact, as a ballpark figure, you can include blood sugar level. But just be mindful that asking for a blood sugar level in a patient who's come in with some sort of forearm pain may not sound very professional. An examiner may think, oh, he's not in touch with the reality. So like to start by obtaining consent of the patient examination. First, start with the cervical and neck region. You don't want, this is kind of station which you don't want to waste time too much. You want to come to those questions which examiners are ready for you. All right. So you need to just jump onto that. All right. So start with the cervical neck pain. So again, looking for any rash, any lumps, any sort of deformity. Why? Because you're thinking of differential diagnosis in your mind. Could it be any sort of autoimmune arthritis? Could it be rheumatoid arthritis? it could be tender if I'm feeling that. The patient or the examiner will give you that finding. Yes, when you're expecting there's no rash, there are no lumps, there's no deformity in terms of curvature of the neck, and there's no tenderness or there is tenderness. Now, whenever you're feeling midline and paracervical, parathoracic, paravertebral, vertebral tenderness of all the spine, also all the way down up to the cervical lumbar spine, all the way up to the SI joints. That is important because if you're checking for the tenderness, it could be excluding the diagnosis of discitis, polymyalgia rheumatica, osteoarthritis if it's the shoulder involvement, the hip involvement, the knee involvement. Okay, so so this is where we are doing actually a diagnosis led examination to save time. Now, movement in the neck and back is limited. And as I said, this scenario said that he's often stiff in the morning. So when you're moving the neck of the patient, like simple flexion and extension movements, and rotational movements, he may say that I'm feeling stiff. And you may get an idea, oh, it could be polymyalgia rheumatica. It could be rheumatoid arthritis, but it could still be. So you're narrowing your diagnostic funnel here. When he's saying, oh, it feels very stiff. You also are expected to check for signs of red flags, radiculopathy. So check for the power in terms of shoulder, forearms, hands, and fingers quickly. Just, can you do this? Can you do? Okay, fine. So just speak as you go along. Now I'm going to check for the power of the shoulders in terms of active. Okay, yes, he's got 5x5 strength in terms of extension, flexion, extension, flexion, extension, and of the hands as well. So in that way, you're just making very good effort of showing that you're conducting the neurological examination as well to exclude radiculopathy. All right. Shoulder exam, it could be a rotator cuff tear. Just examine the shoulder. And whenever you're examining the joint, look, feel, move, and do the special test as required. Now, examiner may tell you at that point the shoulder examination is fine. Don't waste time, move on. Now, also, the patient is actually come in with stiffness, muscle pain. So it all points out to some sort of musculoskeletal diagnosis. I know that. But whilst you're there as a differential diagnosis, you're also complaining of lethargy and tiredness. Okay. So examine for the neck for any lumps quickly, any thyroid mass, any lumps in terms of nodules, goiter. Examine the eyes and hands for pallor. That is important in terms of lethargy. Okay. Or even if you can't do it, just mention that ideally I'd like to examine for the eyes and hands for pallor anemia, checking for hematological malignancies you're thinking of, like lymphoma. They can all present in that age with the lethargy and tiredness and lymph nodes. Also mention that you're going to quickly do respiratory and cervical exam, cardiovascular examination. Why? Because cardiovascular examination, you're cognizant of that aortic stenosis can present with the shortness of breath, lethargy, exertional dyspnea, and the murmur might be there. So this is going again very holistic. The crux of the examination, no doubt, is musculoskeletal and radiculopathy. But then by mentioning that I'd like to look for the neck for the masses, especially the thyroid masses, the goiter, I'd also like to check for the pallor because this patient is presented with lethargy. He may have an underlying anemia or hematological malignancies. Cardiovascular and respiratory examination, he may have compromised cardiovascular system and state. So this is all very important. Now, the examiner will stop you after your examination and will ask you, what is your diagnosis? What is your differential diagnosis? Now you may start to think about what is your diagnosis, and based on your physical, and whenever you're giving examiner an answer, you don't say my diagnosis this is you based on the clinical history in examination. My main diagnosis or provisional diagnosis is polymyalgia rheumatica, because the patient is coming with the symptoms of morning stiffness which gradually improve in the day. He's actually got some paracervical and parathoracic spine tenderness which is non-specific, but there's no active joint involvement. My second diagnosis, it could be a chronic fatigue syndrome, which can also present with morning stiffness. But I'd like to check numbers, especially ESR and CRP, to make sure that there's no component of inflammation. The CRP and ESR would be particularly raised in a conditions like rheumatoid arthritis. The third diagnosis could be polymyositis. But again, I'd like to be further tested that there's no actual large muscle group pain. There's no history of active infection prior to that. But I'd like to collaborate that with normal ESR and CRP, and also checking for elevated CK, because in muscle breakdown, the CK would go up. All right, and that would also point out to any sort of polymyositis can also be associated with underlying malignancies. Now, I'd like to exclude the malignancies like myeloma, lymphoma, and for doing that, I'd like to do a set of blood tests, and you can go through the detail of that. Hypothyroidism is very important because the patient's complaining hot and sweaty, losing weight. So losing weight, hot and sweaty, it encompasses all of the malignancy, neoplastic lesion, thyroid problem, metabolic issues, all of that. It covers. So remember, now that you've given your provisional history and diagnosis, you've come with a completely good framework. Based on my history examination, the most likely diagnosis is polymyalgia rheumatica. I'd like to do blood tests, make sure the CRP and ACE are fine, because they would not be expected to be raised. Also, the patient's morning stiffness and gradual improvement points out towards this diagnosis. Having said that, I'd like to exclude other conditions like polymyositis and chronic fatigue syndrome, and also exclude malignancies like myeloma because of the age factor, lethargy and tiredness, and thyroid issue. Then the examiner, what tests would you like to do? Now, based on the demographics of the patient, you can say that, look, initially for the some of the tests we've already touched base on. For polymyalgia rheumatica, it's full blood count, checking for hemoglobin. So whenever you're giving a test, tell them why you're doing that test. So full blood count, checking for anemia and white cell count, electrolytes to make sure sodium and potassium ratios are okay, and CRP and ESR, which I expect to be normal in polymyalgia rheumatica. But if they're elevated, I'd be dealing with some sort of other diagnoses like infection and CRP. I'll give you one tip here practically. Day before actually, a GP sent me a patient to emergency department with a CRP of 112. And the patient was 20-year-old. And when I took the history from that patient, he said, "Oh, doctor, I just feel tired." And he was a university student, okay? 20-year-old, fit, healthy, good looking student. And he said, "I just feel tired. And I noticed that he's very sweaty as well." He said that I often go and play, football at the weekends, but I'm not being able to do that because I've just been feeling so tired and lethargic. But he did not have any fever. He did not have any tachycardia. He did not have any source of infection, but his CRP was elevated. And for me, having seen lots of patients in this kind of scenario, if the CRP is elevated in the absence of white cell count, it is often a pointer to a nasty diagnosis. So we did a chest X-ray. The first clue was he had mediastinal widening like that. All right. We did a CT then. He had a huge lymphoma. I did a bedside ultrasound. He also had pericardial effusion. So that initial prompt for the GP, very diligent GP, just for the CRP, he did not say or ask about any malignancy. It was me who sort of reflected on that thought process, repeated the CRP, which was still elevated, and did then X-ray and septic workup and found mediastinal widening, and then CT confirming a lymphoma. So just be sure, the point of sharing this story is that often an abnormal blood test is put there for a specific reason, and you need to take into consideration that what are you going to do next if the test is abnormal. A single abnormal test may not lead itself to the diagnosis, or it may not lead itself to the management directly, but may be there to invoke a thought process. I need to do further tests to confirm that it's not a malignancy, like we did in this case. Also, I'd like to do check for the CK to exclude polymyositis, electrolyte abnormalities that we've talked about, and thyroid function tests. I'd like to get an ECG just to make sure that he's got no underlying heart block or underlying atrial fibrillation. Now, the last task of the question was advise patient about the diagnosis and further management plan. Now, that's where your domain of 7 marks is working in your favor. So you can say, "Hello, Mr. Peacocks. My name is Dr. Rizwan Qureshi. Look, I'd like to talk to you about your problems of muscle aches. Now, based on my history and examination, it is likely that you're suffering from a condition called polymyalgia rheumatica. In order to confirm this, I'll have to do some blood tests. And it's quite specifically what I'm looking for is inflammatory markers like ESR and CRP to exclude some of the other differential diagnoses like polymyositis, rheumatoid arthritis. If the results show an elevation of those inflammatory markers, I'd like to start you on some steroids. Oh, if the results show elevation, then I have to talk to the rheumatologist, to get a more specific plan in your management. Right now, the plan in your management is going to be based on a combination, initial analgesia, steroid treatment to reduce the inflammation in muscles. And then I have to check whether there's any contraindication in terms of starting more specifically the steroids, which I'm going to start, like any sort of GI upset, any sort of hyperglycemia or diabetes. So whenever you're starting the medication, especially in the non-steroidal and steroidal medication, ask the patient about the GI upset, ask the patient about any sort of contraindication and allergies. Also, as I said, I'd like to look for other issues which may cause lethargy, tiredness, and weight loss, quite specifically thyroid function tests. Also looking into various tests related to your blood and lungs without, giving the obvious diagnosis that I'm going to look for a cancer. Don't say that. But I'd like to investigate the problem of lethargy a bit further by checking your thyroid function test, some lung test, and abdominal test. Okay. And prostate test, you can do a prostate specific antigen. All right. Now, again, tying it in, summarizing. Now, I see that there's a lot of information, but let me just reiterate the fact and tell you all that slow. And if you've got any question, you can ask that. Okay. Now, I would also like to organize for an outpatient rheumatology review for your condition to be monitored between myself and a specialist and see how you're responding to the steroid treatment that I'm going to start in you. Have you got any questions for me? Thank you very much. And then you finish your station. I'll stop there for about 30 seconds. Now, have you got any questions here for me in regards to this scenario?
You don't have to repeatedly inform the examiner and the patient that we're going to rule out everything. Obviously, we're going to summarize that in the end. In the beginning, when we're examining the patient, we're giving the differential diagnosis, we can just say that these are my differentials, and we would like to further investigate that once we get to that. So maybe that could be the approach to this scenario, because it would.
That's completely fine. You don't have to repeat. In fact, that is the point I cannot emphasize enough, that you have to repeat all that in back and forth, because I'm doing extempore out of that. But you can just make a plan initially that this is what we're going to do in terms of ruling in and ruling out, and then work around that strategy. That's a very good point. Any other question? All right, we'll move on to the third scenario. So critical errors in this station, which were marked, were the failure to do a musculoskeletal examination, which is quite obvious, and also diagnosis, not considering the suspected diagnosis of polymyalgia rheumatica, and failure to do the CRP and ESR, and consideration of malignancy and thyroid-related issues. Now, moving on. I'll just move on. Last scenario will do. Again, same approach, simple scenario. 42-year-old lady Jody Albert presents to emergency department with central abdominal pain and vomiting for the past 2 days. Take a history from the patient, explain to her the results and diagnosis, and what would be your management plan. Now, these are the investigation. I'll give you time to absorb all that, and then we'll go through the scenario. Now, everybody can see those chests. You can unmute yourself if that's. This is the last.
Yes.
Yeah.
Yeah.
So,
do they not give us the normal values in the exam?
They will. But it's just like, I was trying to fit in the normal value. It was just becoming too busy. So I thought, oh, look.
Fine.
Yeah.
Okay.
So, okay. Would anybody like to tell me what's wrong with this patient? I think it's pretty obvious.
Lipase is increased.
Lipase is definitely
non-gallstone
increased.
pancreatitis.
That's, yes, good. Yes. So it could be gallstone pancreatitis. What else could be there?
Non-gallstone, possibly
Non-gallstone.
non-gallstone.
Okay. Because the ultrasound is, that's right. Sorry.
Normal.
Non-gallstone. Okay. Ultrasound is normal. Okay, so non-gallstone pancreatitis, alcoholic pancreatitis, infective pancreatitis, number of other conditions. Okay, so moving on.
Even the liver enzymes are all deranged.
Yes, yes. Rival
Yeah.
enzymes are also deranged. All right.
Yeah.
So make some main diagnosis and the provisional and differential diagnosis in your mind, and we'll move on. All right.
Mm.
So the task of the station is to take the history from the patient, explain to her the results and the likely diagnosis, and what would your management plan would be. Now the you've all seen the results, and it points out that this patient has got pancreatitis with a normal ultrasound. So it points out to that, look, this pancreatitis is, so the two main common causes of gallstones in this countries are alcohol and gallstones. All right. Now, having said that, for the purposes of the exam, if the ultrasound is negative, you don't have to explore the ideology behind the gallstone, CBD stone, small remnant, stricture, or anything like that. Okay. But for the practical purposes, a normal ultrasound could still potentially mean the patient may have stricture, the patient may have sludge. There could be any other thing which could be abnormal and still cause pancreatitis. But just keep it simple. Right now, for the purpose exam, it could be pancreatitis related to the alcoholism. So again, in terms of focus history and examination, I'll start off with my common, introduction. Hello, Mrs. Jody Roberts. My name is Dr. Rizwan, and I'm one of the doctors in emergency department. Now, before I proceed, what I'm going to do?
Vitals.
What is, sorry?
Vitals.
Check the
Pain and vitals. Pain and
yeah,
vitals.
no. I'm just, yeah. So basically, now I'm about to take a history from the patient. But before I proceed with the history, what I'm going to do?
Explain to, take consent.
Yeah. So pain is the main thing which I'm trying to come to.
Yeah.
The patients come in abdominal pain. So pain is the main issue. So before I proceed, I would like to ask you if you're comfortable, or have you had anything for the pain and vomiting? So remember, with the patient, when they came in, she came in with the abdominal pain and vomiting. So there should be your red flags there, that I'm not going to go in and start asking the history immediately. I'm going to ask about the analgesia first, and also the vomiting if she's had antiemetic. I often forget about that even now when I'm going to approach the patients in emergency department. And it's the nurses who remind me, oh, doctor, she's vomiting. Would you like to give her something for the vomiting? And I said, yes, that's a very good idea. Let's do that. Because, the patient who's comfortable in a real life scenario is a better patient to give you a better history. An examiner would be marking you on that anyway. So, hello, Mr. Jody Roberts. My name is Rizwan. I'm one of the doctors. But before I proceed, I'd like to check if you're comfortable. If not, I'd like to give you some analgesia. Are you allergic to anything? No, my preference would be to give her morphine, 2.5 milligrams IV stat, and an antiemetic like ondansetron, 4 milligrams IV stat. Thank you. Then turn to the examiner. I would like to know if the patient is stable. I'd like to know the latest vital in terms of blood pressure, heart rate, temperature, SATs, and blood sugar level. And they'll tell you the patient is unstable or stable. Okay. Now, focus history. Again, you can start off with the pain trigger, duration, location, and severity after 10. I'd like to ask the pain severity after 10 because it helps me gauge the pain requirements, the analgesia requirements, sorry. If I've given the morphine initially, then how am I going to titrate some further morphine or some further analgesia? The pain is now reduced to 10, from 10 to 7, 7 to 6. Then it'll help me pace my or calibrate my analgesia. So just be careful when you're asking about the pain. Just put in a number there. It's just very natural. It's very practical. Now, radiation of the pain, aggravating and relieving factor, and associated features, which she's telling that she's got vomiting. Also inquire about if there's any diarrhea and if she's had any associated fevers, which may point to the fact that she may have any differential diagnosis of gastroenteritis, vomiting, abdominal pain, and fevers could be related to gastroenteritis. Now, does the pain get relieved after vomiting? Now, what would that signify? The patients with chronic abdominal pain condition often say the pain relieves after vomiting.
Some
Anybody?
ulcer. Some ulcer.
Okay, vomiting is very acidic. It also causes more pain.
I don't know.
So gastric outlet obstruction, yes, it could be a complication of an ulcer in which there's a stenosis in the pylorus, or if there's a small obstruction at the level of the stomach, or it's a bowel obstruction. Then all that pressure builds up and causes the vomiting. And by relieving that pressure in the way of vomiting, the pain comes good. So that points out to some sort of mechanical obstruction to the GI tract. So that's just a way of exploring that ideology. Have you been taking anything for the pain which has helped you, and to what extent it's helped you? Now, once you address the pain, it's often good to talk about, let's talk about the vomiting. How long have you been having the vomiting for? And what are the triggers? Are there certain food? Have you had anything in terms of takeaway, the food which may have gone off in the fridge? Any blood in the vomiting? Okay, they'll tell you about the content of them. Okay, and then you explore that. Now, any triggers in terms in particularly related to non-steroidal and steroidal medication that she may have taken, and that could have triggered not only the ulcer related issue, but also can trigger pancreatitis. Steroids and non-steroidal can do that. Also, as I said, ask about if this condition has happened before. All right. And what was the outcome of that? Patients who get pancreatitis often get acute on chronic pancreatitis. They may have a condition called chronic pancreatitis, in which they may represent with the pain over and over again. And in that context may have a normal lipase, but would still mean that they have got a pancreatitis. And last thing we often forget about it, inquire about trauma. There could be a traumatic pancreatitis, like she may have a trauma, falling or injury on the epigastric region a couple of days before. I've seen traumatic pancreatitis 3 or 4 times in a sequence of seat belt injuries. So just be mindful whenever you're entertaining a diagnosis, cover all common aspects of the causation of that diagnosis. So the main differential diagnosis, as we said, that we were talking about the alcoholic pancreatitis, we're talking about the gastric or duodenal ulcers, and on the fringes of it, we are also considering acute coronary syndrome, because this could also be an abdominal epigastric pain related inferior myocardial infarction. So have a broad differential when you're starting on, and have a plan to nip out that broad differential as you go along. Now, in terms of the uh, sorry, I'll go on. Now, in terms of the um, history further, you need to ask about, as I said, acute coronary syndrome, chest pain, exertional dyspnea, also any other infective triggers in terms of social history, in terms of any infective triggers of infections. Social history is very important here. Now, it's so important that you can factor in the alcohol right from the get-go. Like, you can ask the alcohol history in the scenario, or you may like to tie it down, like amount the alcohol intake. And the patient say, okay, fine, I consume about 3 to 4 beers and a half a bottle of vodka every day. Now, that's very clear-cut indication that the patient has got an alcoholic pancreatitis. Now, when you hear the alcohol word, go immediately to cage. Like, have you ever felt to need to cut down on your drinking? Have you annoyed people by criticizing? All that guilty questions, annoyed questions, eye-opener questions. So if you've dealt with the alcohol dependency issue there and then, I'll tell you why. Because these questions are going to tie in with your eventual management plan when you're referring this patient to the drug and alcohol services. And when you're making a referral to the drug and alcohol referral, then you're going to highlight this patient, this position of the patient, that yes, she feels the need that she needs to cut down. She feels annoyed because people are constantly criticizing on her in terms of a drinking habit and so forth. Now, for female patient, for this patient, past medical history, as I said, is very important in terms of, gallstone, peptic ulcer disease, or duodenal ulcers, or any other conditions. Also, any female patient asked about their last period, abdominal pain, vomiting. It would be very silly not to ask about their last menstrual period. It could be pregnancy, basically, what I'm trying to highlight. And so ONG history is important. You can quickly ask them as a tick box thing, and examine. Start with the vitals. Ask for the vitals again. Okay. Abdominal inspection. Now, this is where the focused examination, it will be important in terms of inspection, superficial and deep palpation, organomegaly, and checking for any of the specific signs. But before you proceed on to examination, Mrs. Roberts, I'm going to have to examine you and look at your tummy and listen to your chest and cardiovascular system as well. And promise I'll be very gentle. If it hurts, let me know. You ask for the vitals, the examiner gives you vital, and then you go on for inspection of the abdomen. I say that, look, I'll be inspecting from the foot end of the bed, looking for any overt features of shallow breathing, which would be a sign of peritonism. So you're making a link, which would be a sign of peritonism, thinking it could be an intestinal perforation. Then I'll examine for superficial tenderness, scarring, or rigidity, which again could be sign of peritoneal irritation. I'll check specifically for a specific sign of Murphy's sign, which would be a sign of gallbladder. You could still get acalculous cholecystitis. So Murphy's sign would still be relevant. Check for any renal angle tenderness. Say that I'll check for the renal flank tenderness. And then I would like to complete my examination by doing a rectal examination. Obviously, no abdominal examination is complete without a DRE. Conduct a cardiovascular examination because there could still be differentials of inferior myocardial infarction, could be a non-STEMI, STEMI. So by doing a cardiovascular examination, you're showing to the examiner that your differentials are still broad. And the examiner will say, yeah, cardiovascular examination is normal, proceed. Chest examination is normal, proceed. Because why chest examination? Pneumonia can give you. Quite often the patients present with pneumonia, present with abdominal pain, and we do an abdominal CT which catches the basal slices of the lungs, which shows that they've got pneumonia. So always listen to the chest when you're doing an abdominal examination, or at least mention that. Now it comes to the point when you have to explain to the patient what you're going to do. So explain again, Mrs. Alberts, after completing my assessment and reviewing your blood results, the diagnosis appears to be an acute pancreatitis secondary to alcohol intake. Now, acute pancreatitis basically means that your pancreas are inflamed or swollen. And this is the likely reason for your pain and your vomiting. Some of the other reasons could be gallstone, but it's unlikely in your case because your ultrasound is negative. Now, my plan, now you have to, because you're talking to the patient, but at the same time indirectly communicating to the examiner, make sure that your plan is simple enough with closed loop communication that you're highlighting the medical side of things as well. Now, basically your marriage plan need to highlight the following thing, that we need to admit you under a surgical team. We need to give you an analgesia, which would be a combination of strong and moderate analgesic. My preference would be fentanyl or morphine for strong pain management and paracetamol for mild to moderate pain management. I'm also going to start you an antiemetic, which is a medication for the vomiting. My preference would be metoclopramide or Maxalon to control the nausea and vomiting. Now, the other key cornerstone of this condition is rehydration. You do look very high. So, sorry, I forgot to mention in examination, you have to assess for the hydration as well by mentioning the mucosa. Rehydration with IV fluids. I would be basically going for a targeted IV fluid therapy with a normal saline and targeting your urine output to guide my subsequent fluid hydration management plan. We may also have to do further tests like CT of the abdomen to check for the pancreatic inflammation, cyst, abscesses, or any mass that may have led to this condition. The other important thing that I'd like to talk about is to identify the underlying cause and deal with that underlying cause, which seems to be alcohol. And with your consent, I need to refer you to drug and alcohol services so they can come and review you and offer a rehabilitation program after you discharge from the hospital. So you're tying in a very holistic plan, both with the analgesic, antiemetic, admission under the surgical, especially IV rehydration. But when the patient is going home, you're trying in it with the drug and alcohol. Now, often, as I said, the alcohol could be just a tip of the iceberg. There could be some secondary issues, and you could explore that as a part of your history. That quite often, heavy alcohol could be secondary to mental health issues or significant problem. This is not a part of this scenario. I'm just mentioning that if there's a lead to that, the patient is depressed, then you need to explore that further. Because in this case, what I'm trying to highlight is this is an alcohol related pancreatitis. So you need to address both pancreatitis and alcohol side of things. So starting her on thiamine would be very reasonable. Okay, starting or putting her on a withdrawal scale would be very reasonable right now in the hospital. But if there is a mention of depression, then tying in the alcohol with the mental health assessment would be very reasonable. Okay, this is not that scenario, but if there's included in that scenario, you have to mention that. Now, also ask about if there's any friend or relative who you can contact for the patient because she's admitted, she's young, she's by herself, they can come and support her. And again, tying it in with a summary. Mrs. Roberts, you've got a pancreatitis from a heavy alcohol intake. We're going to manage you by admitting into your hospital under surgical specialties. We're going to manage the pain, the vomiting, rehydrate you, and keep an eye on your pancreas by doing the imaging to make sure there's no complication. Now, this admission may last a few days, and during this time, we'll take the opportunity to make sure that you're seen by the drug and alcohol team to offer you some help with an ongoing support for the rehabilitation from a program from the alcohol point of view. Is that okay with you? Does it make sense? Have you got any questions for me? All right. So the critical error, as I said, was that failure to admit the patient. That's pretty obvious. And failure to take the drug and alcohol history and subsequent referral to drug and alcohol, social health or mental health history, if there's a trigger point of depression. Now, does it make sense? Any question from that point of view?
I have a question, Dr. Rizwan. With all due respect, shall we add some general appearance as well? Because
Absolutely,
there
absolutely.
is
So,
jaundice and dehydration we can put in there, and especially if you are thinking of cholangitis as a DD. She's complaining of pain, cholangitis or hepatitis or whatever. So we can put jaundice as general appearance because then we can rule
absolutely.
out also for edema and ascites and all that.
So three things would be crucial: overall appearance, okay, in terms of lethargy, alertness, GCS, hydration assessment, anemia assessment, and jaundice assessment. This station would not be complete without that.
Yeah, that's what I was wondering. So I think we missed it in the vital part.
Yeah, no, we need to do that. But remember that there are various, there would be an abdominal station related to pancreas, and you could be critiqued on number of different things.
That's right. Yeah.
So tasks are important.
Mm-hmm.
Okay,
Yeah.
so yes, it's a focus examination, and you could spend 30 minutes just by doing an focus examination, excluding and including everything.
Yeah.
But at the same time, this is also tasking you to manage the alcohol pancreatitis.
Yeah. Sure. Yeah.
So there would be no allowance for, obviously doing a good general physical examination and a very thorough abdominal examination, which we IMGs are at comfort level. But at the same time, what it wants you to do is to talk about alcohol, which is a task linked to a pass fail thing.
Hmm.
All right. So you're right. Absolutely right. You have to mention that quickly and move on that. But if at the same time, equally important, in fact, more important because it's a part of the task, is to
Yeah.
not to forget about the alcohol, drug and alcohol rehabilitation services from that point of view.
Yeah, I was just thinking of the DDs, what comes in my mind when the patient coming with abdominal pain, because it could be hepatitis, cholangitis, or biliary colic, or just acute cholecystitis as well. So we can think of jaundice and
Yep. Yep.
dehydration, because you did mention dehydration that you have to hydrate, but why you have to hydrate? So you have to find out the level of hydration first thing in the general appearance. Look at
Absolutely.
the hydration level. So that's what I was wondering. Yeah.
Absolutely. And
Thank
plus, the patient is also coming in with the complaint of vomiting.
Yeah.
So
Yeah.
it points out to the fact that you have to assess with the hydration. You're absolutely right on that.
Thank you. Thank you, Dr. Sam.
That's okay. We'll move on to quickly to some basic tips about communication. And it's just like open board communication styles and tips, which I think are relevant. So basically, communication is the key. We'll talk about some of the aspects of communication which are important from the online examination point of view. Some of the uh, some of the people who've taken the online exam, I've had a chat to them in terms of organization, and I've actually told them how to approach and deal with the whole scenario. So make sure that you dress formally. Make sure your background is, free of clutter. I don't know if it matters a lot, but if your background is sort of light, make sure you wear dark colors so that sort of you don't blend into your background. And if your background is dark, then you wear white color or vice versa. It's not something which is, make or break deal, but I would like to make sure that this point is there for you to understand. It just adds on to the value. Now, also, uh, it is very important that you haven't got any noise, no children, traffic, TV, anything like that. Close the windows. You may like to get an extra light because sometimes light is not sufficient. The exam is conducted by the Zoom session with the breakout rooms, so you might like to use LED light that is commonly available from Kmart, Big W, and anything like that. Also, make sure your computer and laptop is connected to the power cable at all times. You would be surprised how people forget, and then panic mode sets in. Oh, my computer battery is only 5% left or something. And check your Zoom login details and password 2 days. Make sure you've written your password, so at least you don't land yourself into any sort of trouble. Headphone and mics are important. It is also recommended by the AMC that you use headphone and mic. Make sure that you are seated. Now, one of the important thing about seating in terms of non-verbal communication, make sure that your level is chest up and you're within the frame. It's not like you are looking too much down or looking too much up. It just looks unprofessional and uncomfortable. So make sure that you're happy with your setting. If you used to have to use books or any level of raise for your laptop or your communication device, that make sure that you're happy with your angle, and give it a dry run with your partner or your friend. Make sure that they are saying, yes, you look okay, the lighting is okay. All right. And if you've got a laggy internet, I don't think that should be an issue now in this day and age. Zoom performs pretty well, even with the normal 3 or 4G. But if you have got a laggy internet, just make sure that you speak in small sentences. So small sentences you can cluster and then move on. Cluster and move on. So that'll still try and maintain the flow, given the constraints of an online environment. Obviously, there could be a lag. But often when you're saying sentences for a long time, which I may have said during the session, it sort of goes into an echo mode. So just be mindful that use short sentences. Everybody okay here from that point of view?
I have a question as well, Dr. Rizwan.
Yes.
I heard that you cannot use your MacBooks. Is it right? Or is it
MacBooks,
Apple, like
Apple
Apple
MacBooks.
laptop? Yeah. Is it the right information, or you have to?
I'm not sure about that, because laptops
No,
is what
I don't know, I
been
heard it from
advised.
someone.
actually, no. You can use your MacBooks as long as your Windows is compatible on it. You can
Okay.
use any PC, but your Windows should be compatible, because they're going to take your IP address and see that you have nothing stored on your background. It should be an empty computer, basically.
All right, but Apple should be fine, yeah?
Yeah,
Apple should be fine.
yeah,
Yes.
yeah.
Some people have already taken it on MacBooks.
But
Okay,
operating
because I don't know, some of the
system
candidates who were supposed to have an exam, they said that AMC told them that it has to be a different laptop, not MacBook. So,
Look, I mean, if
It's not.
that's the thing, get a very specific query, use a MacBooks. There is no update on the website that I could see. And this is the first time I'm hearing it, but I've heard that people are using MacBooks comfortably. But
okay.
if there's any specific advice, please check with the AMC before your exam.
Sure.
Yes, because I
Because
think iOS is not compatible. That's the thing.
But it's Zoom. Zoom is all Chrome based and all things. So it
Yeah,
should
that's
not
also
be an
true.
issue. Yeah. Anyway, but it's a good point.
Mm.
Please explore that. And if that's the thing, let me know. That is new.
yes, someone
Yes,
is
please.
writing it here. MacBook can't be used. It's mentioned on their website. See,
No,
that's
no,
what
no, sorry. If you read the instruction, you could use the MacBook or any Apple product, but you have to run it on Windows 10, not iOS
Yeah.
program. So
Oh,
you
okay,
have to
okay.
pay
Yes,
So basically,
exactly.
so you have to boot
software.
camp it basically. So MacBook can run both Windows and iOS. So iOS may be untraceable from the IP address point of view, but if you use
Mm.
Windows as a boot camp on MacBook, you can use it. And maybe that's what some of the participants that I was engaged with may have done that. So that's a good point. Thank
Also,
you for highlighting that.
Dr. Rizwan, I just want to ask, are there any centers which are allowing you to, because like to just set up the whole exam scenario at home, and for some people it gets a little hard. So are there any centers that we can go to? I mean, just like out of the box question. Or do
Are
we
there any
like set
center?
up like to
like
take the
PT,
exam, or
just like PT,
like,
isn't it? Yeah.
yeah, like what
like
I mean
an
is that, yeah.
like an online center, or what are you talking about? Sorry.
Yeah. Like for example, like when we went to give for what, is there any place where we can go and take our online AMC exam rather
Not
than
at
set
this
up
stage. Not
at
at this
home?
stage. Not at this
Okay.
stage. Somebody was telling me the other day in Canberra, they were trying to do that or trialing that, but I'm not
Yeah.
sure. It was a bit of a discussion. It did not really eventuate that there was really a premises like where you can do because it defeats the whole purpose in terms of logistics. If you're trying to provide the logistics at online exam at a center, then you're not really adhering to that rule of, that.
Social distancing.
Yeah, exactly. So
Because
because I mean, remember, when you're trying to conduct an exam, inviting people, it's not just you and doing that exam on a computer. It will be a barrage of people, like at least 5 or 6 people would be facilitating that exam. They have to come. Like when you do online IELTS kind of thing, you still have to go to a center and they're like 4 or 5 different people. They have to check your IDs and all that.
That's what I meant actually. Because here the internet is your responsibility. To set up the room is your responsibility. So I read somebody's feedback that she lost on 2 cases because her internet fell down or something like that. So I don't know whether she passed or not, but that's just like bad luck. You know?
Look, one of my friend is an AMC examiner. He's also an emergency consultant, and he was telling me they're trialing the online exam right now, and they've conducted, obviously, he told me that they were trialing when they were trialing the online exam. And he said that once it's introduced, they need to get the backlog, which is a huge backlog right now. There's so many candidates who are waiting for the dates. And once they get the backlog and review the situation at quarterly intervals, if the AMC exam in an online format without any hiccups is going normally, that will become pretty much the norm, yes, to get through the backlog. But if it's not, then they will open some pilot centers within states. Like it's not going to be Melbourne as it was, because in what Emergency College has done is that they are conducting fellowship exam within every state. Previously, we used to go all to Melbourne to do the exam in AMC Center, actually. So that's what I did my fellowship exam as well, in AMC Center. But because of quarantine, there was a lock, there was no exams, and now they've opened up the exams in the local states. So I think that's how it might eventuate. It's some sort of hybrid combination between online and local states, and for the rural, they might still be allowed. The GPs have done the same thing. It's all gone online.
But they're not taking it from home, right? They're not doing it from home, are they?
They are doing it from home, yeah.
Okay.
All right, we'll move on.
Yeah.
Okay, so AMC communication skills. Like, look, this is one of the most important slides, if I can say. Let's talk about nonverbal communication. Like, what I mean by is always greeting up with a warm welcome. Like, this is really important for you as much as it's important for the patient. Hello, Mr. Mackey. My name is Dr. Rizwan Qureshi, and I'd really like to help you today. I understand that you've got some pain in your chest. Would you like to tell me more about it? That opening sentence, that's like a first impression. If you seal the deal there, then all of your session will pace itself. Also, if you can you please make sure that you wear a smile? If the scenario is not, sorry, you okay? Everybody there?
Yeah, it's okay.
All good.
Are you there?
Yep.
Yeah, we can
hear you.
Just give me a second. Can you hear me?
Yes, we can.
Okay. Yeah, I think my headphone disconnected and reconnected again. Okay. So wear a smile. If the scenario is not a crisis one, for example, if it's a counseling and education session, then you can put up a little bit of smile. So that will help develop a rapport and gel in your personality as well. Again, sit right. Don't slouch, and don't be too much towards the edge of the chair or too much relaxed like that. Just be at comfort level with your body slightly inclined forward. That will give you a good sense of body language in terms of you're equally concerned in listening to them. Now, they often say about the eye contact when you're especially talking to the patient. Now, I find it very uncomfortable to establish a clear eye contact with anyone when I'm talking. I think it looks a bit intimidating, and the patient may get inflamed. So I tend to look at their nose or the lips. So if you can do that, at least that's fine as well. Is that all right? Can you hear me?
Yes, we can.
Yes, we do.
Okay. Now, show empathy in your facial expressions. If it's a breaking bad news or diagnosis, then take long pauses. Sometimes we often think that breaking bad news scenarios are all about, talking and getting to all of that crisis buzzwords. We need to say them out. But sometimes it's all about taking time and listening to the patient and venting them out, and then punctuating that response with your calibrated tools of assessment. Okay, so don't feel the need to say a lot. but show your empathy, not your head if you can, especially even in an online exam. It becomes even more artificial now. You can nod your head, show concern. Yes, I hear you. I hear you. I can understand. Okay, all right. Don't say I completely understand, I can relate to that, because that would invoke that you have got a personal experience. You still have to keep a professional distance and keep up with your professional. I can completely understand. Same thing happened to me, nothing like that. Just nodding hand, having your fingers and lips when you're listening very carefully. That again points out that you're listening with a lot of empathy and concern. Also, sometimes, tilting your head is important. When you tilt your head, it is often a reflection that you're listening to someone very carefully. You may involuntarily do that. So just sharing some of those non-verbal cues. All right. Greet, smile, upright posture we've talked about, eye contact. If you can't, look towards the nose and lips, and use overtones and undertones. Sometimes there's a lot of information, a lot of speech that you have to go through, and you may start, hello, my name is Dr. Rizwan. I'd like to go through your assessment. I'll take a history. I'll do the examination. And we'll talk about some investigations. Is that okay with you? So basically, you've given a heading. Like, remember when you like to write notes and essays, there was a heading and subheadings. So basically, that's what you're trying to do with your, speaking loudly with an open, bold introduction. Yes, I'd like to take your history, conduct the examination, and we'll do some investigations and then taper off and then work out the management plan. What's the best way of going about it? Is that okay with you? Fine, moving on. So that is very important. It actually humanizes you in that very artificial scenario. And that's what we're looking at. That's what I mean by putting yourself in a zone of examination. All right. Now, verbal communication skills. Now, please don't put an accent on. I was recently working with someone, I don't know who it was, but this lady was just completely putting her accent on. And she looked from a background, like from subcontinent background. And I felt so uncomfortable when she was presenting her case to me. There was she was just trying to put up a fake Australian accent. And I said, look, you could do a lot better job. I could have a much more clear understanding of your language if you don't put this face accent. So don't put an accent. As I said, it's not about putting an accent. It's about clear communication. As people should be able to count your sentences. And as somebody pointed out, don't repeat yourself. Often it's a sign when you don't know what to say and when you're running out of options in terms of saying. Now, introduction. As I said, use overtones and undertones. And you can use your introduction overtone. Hello, my name is this and that. Then when you're conducting, what I'm going to suggest now, and I'm going to do an examination. Is it okay with you? All right, moving on. So before every breakage in the task, you can highlight that task with an overtone. Okay, start with a clear and sharp opening, which sort of emphasizes your point to the examiner. I'm doing this task now. Hi, Mrs. Smith. My name is Dr. Rizwan Qureshi, and now you go in an undertone. Now, I believe that you've come to us with some chest pain. Can you please tell me something more about it? Okay, so use that credibility and peaks and troughs to your advantage, and also so that examiner can hear you. It is even more relevant and important because your sound can come across as monotone online. So if you're speaking up loud and then going a little bit not so loud, it will help people understand you better. All right, practice this and you'll ace that. Okay. Now, clarity, we've talked about. A structured approach is crucial. Please, there's nothing more important than having a structured approach. You should have an approach for every scenario, every task, every situation. There should be approach. You should be able to fluctuate between those approaches and not feel, oh, what I'm going to do now. All right. And it should be based on clinical prioritization. Remember, this exam is does not does not allow you to make mistakes when it comes to clinical prioritization and missing crucial key points, especially the red flags. So make sure whenever you're doing your assessment, you're not missing the prioritization tool, like checking the stability, checking the points of the clinical assessment which matter in chest examination for the cardiovascular examination, also checking the oxygen saturation. So don't overlook that key points. Okay, introduction and consent when you're opening up a talk. You can also break down your talk like task 1, 2, and 3. So we're going to do number 1 this, number 2 this, but I feel that it often feels if you forget number 4 task, then it may just fall out of the window. But it also helps organize at the same time. If you go, like, as you said, you may have seen that I broke down my management tasks. We need to highlight on your analgesia, antiemetic, and IV rehydration. You can say that number 1, the priority is to control your pain management. Work on your pain management. Then we need to talk about how can we best control your vomiting. And then we need to work out the hydration plan. So you can clinically prioritize all those situations. And then summarize your plan. Look, patients are in pain. They're often confused what's going on. Summarize and ask them questions from that point of view. Does it make sense? Everybody with me on that one?
I have a doubt, sorry. So is it important to follow the task in the order as well? Like suppose if the first task is history, second.
Yeah. Well, I mean, I think the tasks mostly are organized in that order that you won't be able to complete that. Mostly what I've seen in AMC scenario, the task 2, like if you go to the scenario number 2, I don't know if you managed to see that. The task was to do a focused examination of the patient. And the second task was to answer the examiner question. And the third task was to make the management plan for the patient. So often in most scenarios, to my understandings or what I've taught and did, is the tasks are interdependable on each other. But if you know otherwise, let me know. You should be able to tick most of the tasks throughout the station. And sometimes I know you got a bit more leverage, especially if you've got a task like an open-ended task like history, examination, investigation. You can fluctuate backwards and forwards as long as you're not missing the crucial point. And by God, that's the most natural way of doing that as well. All right, you can fluctuate between the your clinical prioritization tasks as they evolve. Does it help answer your question?
Yes, thank you.
All right. Okay. And as I said at the end, using your overtones and undertones to punctuate your commentary. That's so very important. Now, something about the engagement and empathy and rapport building. Now, often through the task, you can identify like what's the main issue. Is it the pain? Is it the diagnosis? Is it the management? Or is it the counseling? I often tell all my participants that after every 3 minutes or after every spiel of a commentary, pause and ask them, are you with me? Do you understand, Peter? Are you following me? That will help put in again a more humanizing touch. You might be doing an examination. I know that's a lot and you might be feeling uncomfortable. I haven't got long to go through. Now, these are the very important small buzzwords, which again helps you consolidate that. All right. So stop after a few minutes and see if you've got patient on board with them. Okay. We've already talked about laying down the steps in terms of priority, especially with the management plan. Firstly, I need to address your pain, then antiemetic, then fluid, all of that. But then again, keep on checking if the patient are responding to that. Does it make you feel better? Or highlight to the examiner, after the pain, I'd like to come back and reassess from the pain point of view. That could be also the part of your management plan, and which we often forget about that. All right. Now, the other thing is some things are very important. If you've got a septic scenario, don't miss the antibiotics early. As soon as you've taken the blood cultures, as soon as you've taken the appropriate investigations of excluding chest infection, start the empirical treatment early. That's very important. All right. Similarly, in terms of chest pain, if you're suspecting acute coronary syndrome, you have to think about giving the patient aspirin, clopidogrel early on, whilst you're still working out the chest pain pathology, but you've still got an acute coronary syndrome is your main differential diagnosis, especially if the ECG looks ischemic. So remember about analgesia, oxygen, nitrates if it's not an inferior myocardial infarction, but then giving them aspirin and Plavix, and early liaison with the cardiology. I often tell all my participants, when you've got an emergency, the first step should be the referral, stabilize, and symptomatically manage the patient. So if you've got an ECG which is consistent with acute myocardial infarction, you need to have dual priority. I would like to activate the cath lab by calling the consultant cardiologist on call, or I would like to involve my senior to deliberate delegate the idea of having the cardiology lab open. At the same time, I'd like to stabilize my patient by giving the oxygen, analgesia, antiplatelet agents like aspirin 300 milligrams loading dose and clopidogrel 300 milligrams loading dose. So at least, you're showing your clinical strengths, which are expected in those crucial key elements of emergency scenarios. All right. Okay. We've talked about that. And now Australian health system, as I said, is all about collaborating. Any well-developed advanced system is all about teamwork. And, the teamwork is important for us in passing this exam. Your management plan is individual, is not complete unless and until you've got a follow-up with the GP, follow up with the physiotherapy for a terrible back pain or recurrent back pain. If the patient has come in with a musculoskeletal injury, you can refer them for an outpatient physio. If the patient has come in with chronic abdominal severe pain demanding analgesia, there's no plan which is complete with acute and chronic pain team involvement. If the patient is alcoholic, as we've seen, there's no management plan complete without drug and alcohol involvement. So be very cognizant of the fact, physiotherapy, drug and alcohol, early pregnancy services for patients who are having a miscarriage. This barrage of services now. The hospitals are having meetings after meeting to have more services to keep the patients out of the hospitals. The GPs are now encouraged to refer the patients directly to these services. You can pretty much manage the cancer as an outpatient now. Do you know that? So just be cognizant of the fact that your plans need to be holistic. There's your management plan, and then there's a collaborative management plan. Don't forget that. Okay. All right. And always invite questions. You may think that you've done a brilliant job, but it's often a very cheeky question. But you can still factor that, and you can say to the patient, do you think that I've answered all your concern, or have you got still a question or a specific concern that I've not addressed? So if you're missing out something in the examination, the patient may either keep quiet or may say, okay, oh, look, I'm still worried about my abdominal pain. I'm not sure what's the follow-up plan. So last question invite could be used as your advantage. Just you have to be tactful about that. So with that, we'll come to the end. In terms of summary, confidence is the key. It gets rid of your anxiety, it paces yourself, and gives you a complete control of your scenario to successfully conduct all your tasks without fumbling, without setting up yourself into a panic mode. Speak clearly. This is not about accent. It's about clear communication with clinical prioritization and collaborative decision making. And have a methodical approach, meaning you need to have an introduction. You need to go through each and every task as they're asked to be conducted. Summarize your findings at the end and invite questions. You may have missed something, and glue them all in with empathy. Use your non-verbal communication skills and cues, tilting your head, nodding your head, relating with the patient that I'm sorry to hear that. There's no harm in saying, I'm sorry to hear that. I'm sorry to hear about your pain. But just make sure that you say that at the point where it's required to. Just don't overuse that every point. The other important thing which I was telling you is to, after every long commentary, stop and just follow up with the patient. Are you with me? Is that all making sense? So that humanizes your complete interaction, even though it's in for an examiner. There's a lot to be achieved in 8 minutes if you're well prepared. All right. And like I said, always answer the task. The exam is grueling. It's very senseless, and it would not do you any favors if you're not answering the tasks. We've talked about the methodical approach in terms of your clinical prioritization, and don't ignore the patient or their family. If there's some other family member in the room, then acknowledge them, say hi to them. Even if they're not really a part of the scenario, you can You may be given a specific instruction, ignore the examiner, ignore the family member, but if there's a family member, you certainly need to acknowledge them. All right. Now, any questions?
Like you missed in the scenario, in the third scenario, we had missed the dehydration part during the examination, which has been discussed in detail. But what I wanted to know was, what if we do that in the real exam? How can we go back and rectify that mistake? Because missing out dehydration in a looking for dehydration in a patient with pancreatitis is crucial. So if we miss something like that in the exam, um, how do we go back to it? I mean, should we just cover that up during our plan, or should we just say, can I just check your, I need to have your mouth examined. Can you have, can I do that now and then plan it out, wrap
That's a
that
very
up
good
in the
point.
plan?
Look, if you're well versed in a topic, if you've seen and managed pancreatitis, it will come to you. And if you realize that you've missed that important aspect of the management, you can be gracious about your mistakes. And there's nothing wrong with that. After all, it's an exam. Look, Mrs. Roberts, I'm sorry I forgot to examine you from the dehydration point of view. Would you mind if I have a quick look around your mouth? I just want to assess you for rehydration. And if examiner said that's okay, what would you like to look for? I would like to look for, hydration signs into some mucosal wetness and hydration, and also like check for the skin turgor and central and peripheral capillary fill times. Moving on, and then I'd like to gauge my rehydration in a judicious way by giving the blow doses of fluid, mapping it off with systolic blood pressure of 90 and urine output. So you can be gracious about your mistakes as long as you recognize them. That's the more important. It's when I was doing an anesthesia, there was a very good very good example which got told to us that sometimes, in a heat of the moment or in the panic of the moment, you intubate the patient wrongly and it puts the tube in the esophageal way. It was a very common complication back in the old days, that often by the immature people, that they're not very well trained and they would do an esophageal intubation. And an anesthetist, um, you know, was telling that it's not the esophageal intubation which kills the patient, it's failure to recognize the esophageal intubation that kills the patient or takes their life. So you could still make a mistake, but if you are able to recognize that mistake and come back to that, that's no problem at all, as long as you recognize your mistake. And that's, pretty much the essence of the practical life as well.
Thank you so much. Thank you, Dr. Radan.
Anything else, or we done?
Yeah, well, I got a question. During the first 2 minutes, will I be able to use my pen and a paper just to write down what the important points are? Because it was not allowed.
No, it's not allowed in the online examination. I think is a very specific instruction, unless and until they have changed it recently. I don't think any sort of writing equipment or taking notes is allowed in online examination. It was allowed previously, but not anymore. Any other questions?
I just had a question about the format of this course.
Mm-hmm.
Firstly, each session, is it subject-based or it's going to be different cases?
All right. Okay. So we are doing a course. It's myself, an emergency consultant, an FRSEB GP, and we've got an advanced trainee in emergency medicine as well. Most of us have been teaching on various courses and AMC exam as well. So what we have done is we've collaborated. What's the best way of using this very focused approach over 8 weeks? It's all subject based. So basically the crux of the course is that in this 8 week, what we're going to do is go subject wise first. At 4 week mark, we're going to do a mock exam. Okay. And it might be halfway through your pediatric or obs and gynae, but the mock exam is still going to be very random. All right. That will help us identify the key areas where you're struggling. Is it the medical expertise in the area of obs and gynae, or immunology, or medicine, or surgery? And we can give you a specific feedback that, look, you need to learn a little bit more in that area. Your body language or your communication skills are not really up to the mark required to pass this exam. So we can give you this feedback after assessing you at 4 weeks. Then what we'll do, we'll go on again with the subjected approach right up till the very end of the course. Then we'll go do another mock exam. And with that mock exam, we'll be able to give you a complete sort of guidance that, look, we gave you that feedback. Now you've really improved. This is certain tweaks that you can do, and you can improve that self in that. So I think having 2 mock exams, one at the midway and one at the end, will help us sort of guide you better. That's my understanding. The faculty were saying 2 mock exams is going to be very logistically tired and all that. I said, no, we have to do 2 mock exam. I won't be able to judge and give the proper feedback unless and until I know that I have assessed them and I have done something based on their strengths and weaknesses. Like, you may have a very good way of communicating, but if you're not really picking up the task as they are meant to be addressed, then it's going to be very difficult to pass this exam. I don't want you to have that sort of feeling. So yeah, that's how we have organized it, and that's how we're going to do it. So quite specifically in terms of your answer, yes, it's subjects organized, and then the mock exams are random.
So the schedule that we get, the subjects will be written in that schedule.
Yes.
We haven't received the schedule yet, so.
Yes, no, I'm going to send you the schedule. I'm just working out the last few times of the sessions, finalizing the details, and we'll send the session this week, the complete timetable. So it's a live timetable. Basically what you'll have is you'll have a link to that timetable, and all the sessions according to their timing will be there.
Okay, perfect. And I have just one more question. How does the sessions work? Like, we will be divided in groups, because as I can see, there are 22 participants, and we have only 3 hours per session.
They're not 22 participants. No, they're all in this free session.
I just saw that there were 22 participants. So how does it work? Like, each session? Like,
you will all have a case to do. So basically, it's not 22 participants. It's a lot less than that. And in a 3-hour session, you'll all have a case to do, and other people will also be going through the case. So no, they're not 22 participants. They're a lot less than that. You'll be doing, however, one thing which I've made sure from the very beginning, and all of the faculty are doing from the very beginning, is to basically do the entire course from day one in exam conditions. I know it's going to put you on a lot of edge, but I think the only way to improve and continue to improve in all that 8 weeks is if you are doing exam cases after cases after cases after cases in exam conditions. So that's how you're going to really be put on the edge in terms of your time management and rapid thinking. All right. So it's all from day one exam led. So you'll have scenario of exams after exams after exam. And there'll be a lot of critiquing from the social aspect of the things, which the soft part, like, counseling, and which we're talking about collaboration and conflict and patient education. That's going to be also forming a lot of important component of the exam, because I think we often oversee that. All right. So just be mindful of that we'll be having a very 360-degree management and approach on that.
So just, so the session, sorry. Yeah.
Oh, that's all right. Go ahead.
So the sessions, it's all gonna be role plays. Is that correct?
It's all going to be role plays. Yes.
Okay,
so faculty will role play with you, and you will perform in that role play, and then we'll go through the feedback slide. So just as I've done the scenario, as you said, you will be doing that scenario after the task in 8 minutes, and after those 8 minutes, we'll give you a feedback that, look, you've got these critical points that you've clicked, you've passed that station. This is your overall score. These are the things that you could have done better. And this is a thing which you've missed, which should not have been missed. And there'll be clustered of topics. So if there is pediatric shortness of breath, then we'll cluster it with pediatric wheeze as in asthma, bronchiolitis as in, and also other respiratory illnesses like pneumonia. So we can cluster the differential diagnosis that I have tried to cluster the hip pain with Perthes disease and septic arthritis. Unless and until the management is completely different, then we'll break down those scenarios into individual stations. So basically in a session of 3 hours, you'll be doing between 8 and 9 scenarios.
Okay, thank you.
So almost an exam, almost like an exam.
Well, I got one more question. For a candidate who is facing the exam in May, mid-May, are there any mock exams available? I know it's very short duration, but
look, our mock exams are for our candidates because obviously it's very logistically difficult to fit in a lot of people for those mock exam. This is the reason that we cannot allow outside participant. Our mock exams can only be done for our candidates. I'm not sure if there are any other people who are doing just mock exams, but we are thinking of holding more mock exams for the next round of session and courses further down the line. Just right this time we're trying to keep it close within our own sort of hub.
Okay, thank you.
It is a lot of organization mock exam because you have to go every session by time, moving on session by time. We've got quite a few candidates go through, so that's why. But there are a few places in our course, so if you're interested, just let me know. We'll try to fit you in the course. Any other questions? All right, I think with that said, we should stop here. Thank you very much for your time on Sunday. I really appreciate you all, and I hope and wish you all well. I hope you all pass and you're able to work soon, and I think it'll be fine.
Thank you very much.
Thank you.
All right.
Bye.
Thank you very much. Thank you. Bye-bye.
Bye.